Well,
Yes,
thank you
no, no.
so much. That was a really great introduction and very happy to be here. And thank you so much for the invitation. I do have a lot to get through, so I will go through fairly quickly. And if anyone has any questions, please feel free to stop me. Put some messages in the chat or anything you like. So the breadth of vascular surgery is quite large. So we'll start with vascular trauma. And I think one of the important things for vascular surgery is just recognizing anatomic relationships. And so just for some general thoracic vascular anatomy, here's a thoracic aortogram with our ascending aorta, our innominate artery, left common carotid, and our left subclavian artery. And in this view, all these vessels look fairly accessible. But when you look at this in two dimensions, it actually comes back in a 45-degree angle towards the left chest. And so if you have a patient that has an injury to the ascending aorta, innominate, the common carotid of either the right or the left, a median sternotomy is the ideal approach to approach these patients. And so this is for patients that have penetrating trauma that you need to get to the ascending aorta, the innominate, the first part of the aortic arch, the common carotid arteries. The right subclavian artery is best accessed through a supraclavicular approach. And that could always be extended with the median sternotomy to expose the innominate artery as needed. And you may remember that the recurrent laryngeal nerve wraps around, so you have to be careful that you don't get that with a clamp. Don't ask me how I know that one. So in any case, the left subclavian artery is very challenging to get. And so it's really inaccessible from a median sternotomy approach. So I typically approach these from a posterior lateral thoracotomy. And so if the patient is able, if many times patients have polytrauma, but if you're able to, I generally put them on the side, bring their arm over and do a posterior lateral thoracotomy. And you can get access to the origin of that left subclavian artery fairly early. And so here you can see the recurrent laryngeal and the phrenic nerve running down. In patients that you've already opened up the chest, let's say that they've lost vitals in the ED, you've done an ED thoracotomy. The other exposure technique is to do what's called a trapdoor thoracotomy. And so they already have their left chest open. You would then extend for a median sternotomy and then do a relaxing incision for supraclavicular. So even though it's called a trapdoor, that's fairly a misnomer. It's not as if this part of the chest wall opens like a trapdoor. It just allows you to spread the sternum much more aggressively than previous, and you're able to get back there and get a clamp on that left subclavian. But it's very, very challenging. So I would my preference is to do a posterior lateral thoracotomy for the left subclavian, but if needed and you've already opened the chest, this would be the answer for your ABSITE. So moving from penetrating to blunt, as you may remember, the ligamentum arteriosum fixates the thoracic aorta in the chest. And so classically, a deceleration injury will cause stretching or shearing of the thoracic aorta. And most commonly, the injury occurs just distal to that left subclavian artery. Traditionally, these were approached with a posterior thoracotomy, and you would clamp your thoracic aorta between the left subclavian and the left common carotid artery. But in today's day and age, a TEVAR is the most expeditious and safest approach for these patients. We typically grade these into 4 grades, where an intimal tear, we call these a minimal vascular injury that you probably see when doing your trauma workup. And those can generally be observed. The intramural hematomas, I tend to observe them fairly frequently. So if you have a question with a grade 2 intramural hematoma, I generally do another CT scan within 24 hours. I don't think that you have to do a TEVAR for that. The grade 3 pseudoaneurysms, those should have a TEVAR placed within 24 hours. If you have a patient with polytrauma or blunt abdominal trauma and you have both a blunt aortic injury and you also have active splenic injury, the order would be to do the abdomen first, and then bring them for the TVAR. Generally, these are contained ruptures that you do have a few hours at least to deal with. And then grade 4 is the rupture. So this is a life-threatening event. I've only seen one of them. This is a patient that actually made it to the hospital. He fell out a second-story window, and he was able to get to the CT scan. He actually passed away en route to the OR. Another anatomic relationship I'd like to talk about is the IVC and the aorta. So the IVC joins together from the iliac veins right underneath the right common iliac artery. So this is a classic situation where you may have patients that have an injury right to the crotch of the IVC or the crotch of the aorta, and it's very challenging to get to fix this because of that right common iliac artery. If it's elective, let's say that you're doing a large sarcoma resection, generally you can mobilize this aorta and this right common iliac and even get out the external and the internal and swing that over medial. But the board answer, the ABSITE answer, is to divide the iliac artery so you can fix the confluence of the IVC and then reanastomose these end to end. So that is the board answer, the ABSITE answer for that specific injury. Moving right along to extremity trauma. So how do you decide if you go directly to the OR, imaging, or surveillance? And so, as you may know, this is whether they have a hard versus a soft sign of vascular injury. So they'll tell you in the question stem whether a patient has either a hard or soft sign, and you have to determine if it is a hard or soft sign. And then from there, you'll determine what your answer is if you go to the OR, imaging, or surveillance. And so I'm trying to make things as easy as possible. So the easiest way that I remember hard signs of vascular injury is if there's active bleeding or an ischemic limb. That's it. Those are the true hard signs of vascular injury: active bleeding or ischemic limb. As for soft signs, so we talk about injury near a major blood vessel. This is virtually any extremity trauma, especially any penetrating extremity trauma. So as you know, you really don't know the trajectory of a bullet or a stab wound, and you may say, well, you know, it's a bit lateral. I'm not sure if it really injured a vessel. I would say that every extremity trauma that doesn't have active bleeding or ischemic limb should get a CTA, and you will find more things than not. A stable hematoma or massive bleeding at the scene of injury is also a soft sign, or a neurologic deficit. Neurologic deficit can be challenging because this could be a compressive hematoma or an ischemic limb. So that's another reason that, let's say, if you do have a signal on the trauma bay, I would get a CTA. Just to review again the relationships, and this is really important on how you expose the blood vessels. So your external iliac artery travels underneath the inguinal ligament, and so here's your common femoral, your profunda femoris, and your SFA, and these are all in the anterior compartment of the thigh. And as you travel down, this then enters into the adductor hiatus, where it becomes into the posterior compartments of the leg. And so here's another relationship. So here's the vein and the artery. So as you know, when you're getting a central venous line in the femoral, you're going medial to the artery, medial to the pulse. But then in the mid leg, they switch. And so let's say that you need to expose the above knee popliteal artery from a medial approach. You'll run into the artery first, and it's just the opposite. They switch again when you go down for the below knee popliteal artery. So the vein is first as opposed to the artery. And just to review the anatomy, so this is a right leg. You can see here's the fibula on this side. So here's the popliteal artery. So this is in posterior compartments, and everything remains in the posterior compartment except for the anterior tibial artery. So the anterior tibial artery pierces through the interosseous membrane. And so here's the two bones, the fibula and the tibia, and in between is the interosseous membrane. So the anterior tibial artery pierces through the interosseous membrane to go to the anterior compartment. Everything else is in the deep posterior compartment. So everything else is in the deep posterior compartment. So you may have those questions where you need to match up which blood vessels in which compartments. And so it's really easy to remember that everything is in the posterior compartment except for the anterior tibial artery, which goes through the interosseous membrane and remains in the anterior compartment. And so fasciotomies, I'd say, are fairly well represented on the ABSITE and the general surgery boards. And so just reviewing these compartments, I think, is fairly high yield. And so here's a left leg. So here's the anterior compartments. This right here is the interosseous membrane. And then you have the deep posterior compartment, which has everything else. That has the popliteal, tibioperineal trunk, the perineal, the posterior tibial artery. And then there's the superficial posterior compartment and the lateral compartment, which don't have any blood vessels. Here's another view. Again, this is a left leg, or depending which way that you look at it. And so again, here's the anterior tibial artery neurovascular bundle. The perineal artery there's another word for perineal is fibular, and so they run right next to each other. And so you can access or identify the perineal artery by identifying the neurovascular bundle right next to the fibula. The other is if, let's say, you were to come from a lateral approach, you actually excise part of the fibula to get to the perineal neurovascular bundle. And then the posterior tibial neurovascular bundle, as you know, is medial, and that's where you feel your PT pulse is the medial malleolus. So when you're doing a fasciotomy, these are typically two incisions, one incision for the anterior and lateral compartments, and one incision for the posterior superficial and deep compartments. I know that was a lot. And so I think that anatomy for trauma is very well represented. So I can always send these slides out so you just are able to go over some of that, those anatomy relationships. I think will get you several questions. So PAD. So non-invasive testing and ABIs are the cornerstone of the initial diagnostic test. So if you have a patient that you're concerned for ischemic limb, or even if they have claudication, rest pain, tissue loss, ABIs are typically the first test that you would get. I would say that this is for best served in chronic disease. And it's fairly easy to get an ABI. You can just put a blood pressure cuff up over the calf, and then you can listen to the PT and the AT and let the blood pressure cuff down, and you can get a pressure and match it to the brachial. Here's testing that was done in a vascular lab. So you can also get these waveforms. These are called PVRs, or pulse volume recordings. So every time that the heart beats, the limb itself expands. And so these are recordings of the volume of the limb. And so you're not going to get a true dicrotic notch that you do from an EKG or things like that. Or not an EKG, but in terms of those other physiologic drawings. But you will have pulsatile waveforms in patients that have either minimal or no vascular disease. And you can see these are fairly abnormal on the left side. If you see NC, it means non-compressible. And so in order to get a blood pressure, it relies on a blood pressure cuff compressing the vessel and then slowly coming down to get that blood pressure. So those are typically a reference for either medial calcinosis or significant atherosclerotic disease. So interpreting ABIs on the most simple level, normal is between 0.9 and 1.3. Mild is a few points below that. Moderate is around 0.5, and critical is under 0.4 or 0.3. And we spoke about arterial. This relies on arterial compression. So in patients with non-compressible vessels, ABIs will be falsely elevated. So you may have a scenario where a patient who has diabetes or has end-stage renal disease that has extensive medial calcinosis, and their ABIs will be falsely elevated. So claudication. So what's the risk of amputations in patients with claudication? So this is a very common question that we see in clinic, and it's a very worrisome question that patients come in with. And fortunately, the risk is low. It's a 5% risk of amputation at 5 years. And so I tell these patients that the risk of losing their leg is very low, and the risk of transitioning from claudication to chronic limb-threatening ischemia, rest pain, or tissue loss is also in the single digits. It's very low. So we only operate if it's truly lifestyle limiting. And any vascular intervention essentially starts the clock. So we tell patients that whether it's a bypass or an endarterectomy or even a stent, it's likely not going to last them their entire life. And typically, when they go down and they occlude, um, those uh, their symptoms may get worse. And so you may have a patient that you treated for claudication that then presents 2 or 3 years later with an occluded fempop and now has rest pain. And so then they certainly have a risk of amputation. So I'm very, very cautious on operating on patients with claudication. And in fact, the most likely cause of death in patients with claudication is coronary artery disease. And atherosclerosis is a systemic disease, and PAD is a coronary equivalent risk status in the ACC AHA guidelines. I know I'm going fast, so if there's any questions, please feel free to stop me. On the other spectrum is chronic limb-threatening ischemia. And so the risk of amputation is very high. It's about 40% risk of amputation in 5 years. So unlike patients with claudication, where I tell them to stop smoking, keep walking, exercise programs, optimize their statin antiplatelet use, we really I'm much more aggressive surgically in patients with chronic limb-threatening ischemia. So while we do all those other things, those patients I book for an angiogram or whatever the case may be. So patients typically have distribution patterns of atherosclerosis, and older males most commonly have SFA disease, especially males who smoke. Patients with diabetes most commonly have infrapopliteal disease. And so that is probably a very challenging area to treat. And that's why patients with diabetes also have high risk of limb loss, is because it's mostly tibial disease that they have. Young females who smoke typically present with aortoiliac disease, and symptoms usually present one level below the level of disease. So, for example, older males with SFA disease may have calf claudication. Patients with diabetes may have metatarsalgia or forefoot pain. Young females who smoke typically have either buttock or thigh pain in addition to calf pain. So bypass patency rates, you won't need to know the percentage for your ABSITE or for your general surgery boards, but you will need to know that it depends on the inflow, the outflow, and the conduit. So just like learning in medical school about cardiac output as preload, afterload, and contractility, it's really the same thing for the rest of the circulation. So inflow, outflow, and conduit. And so we've always known that conduit is very important, that patients who undergo vein bypasses, especially below the inguinal ligament, have much better patency. But what we actually found fairly recently was the best CLI trial, that single segment GSV is preferred even over endovascular therapy. And so if a patient is able to tolerate a bypass surgery and they have good saphenous vein, I counsel them highly on going directly to bypass rather than endovascular, as it reduces their rates of amputation and also their mortality rates on a long-term basis. Acute limb ischemia, I think, is critically important. These are patients that you are probably most commonly consulted on in the hospital, and the chronic limb-threatening ischemia you probably most see commonly in clinic. And so progression of acute limb ischemia, 0 to 6 hours, you may get a pale limb. After 6 hours, you may start to see mottling, and over 12 hours, that mottling may become irreversible. So an easy way to memorize this is just sort of really understanding, is there sensory loss? Is there motor loss? And is there a signal? And so so the nerves are most early affected by ischemia, and sensory nerves or sensation is the earliest. So generally patients may say that they have numbness, and that is typically the first affected. So maybe they may or may not have a Doppler signal. They have pain in their leg, but they can feel and they have motor function. So they're Rutherford class 1. So they have a viable extremity. So I would start them on heparin. I would get imaging and decide how aggressive that we need to be for this. And many times, patients who are Rutherford class 1 may actually respond to anticoagulation alone. Then we start to go down this cascade where first sensory loss is affected. And so we call this the marginally threatened limb. And so if they do have motor intact, this is a class 2A. And these patients, again, start them on heparin. And then I generally take them for angiogram either that night or the next day. So within 24 hours. The immediately threatened limb are patients who have motor loss, and these patients have a high risk of limb loss. And so these patients start them on heparin, decide about imaging, and I take them to the OR right away. To me, this is a level 1 case. They go right to the OR. The irreversible limb is patients that have profound sensory and motor loss with rigor and inaudible signals, and in fact they lose their venous return signal as well. So we divide this up for acute limb ischemia into thrombi and emboli. So causes of or sources of emboli most commonly are cardiac. We've seen them with aortic or peripheral aneurysms. We see that a few times a year at least. Aortic mural thrombus or paradoxical embolus. And this occurs otherwise in normal arteries. And so patients with emboli typically say, my pain started at 2 a.m. this morning. It woke me up from sleep. So it's typically sudden onset. And in fact, the two causes of sudden onset extremity pain are typically emboli and trauma. Those are typically your two causes. As opposed to thrombosis, where this is typically more of a insidious onset. And so maybe these patients have disease, atherosclerotic disease that worsened over time, where, yeah, I started getting a little bit of sensation problems maybe a couple days ago. And so it's a much more insidious onset. So progressive atherosclerosis. There is hypercoagulability, and so that's probably a more quicker onset. An obstructing dissection flap that you may see from aortic dissection, and of course that would be a quick onset, or anything that we do, ECMO cannulas, arterial lines, percutaneous closure devices, and so those are all causes that would need to be addressed. So the question is, for your ABSITE and for your oral boards and gen-surg boards in real life, do you need imaging before going to the OR? And also, what imaging do you need? So in my practice, if you have a known cause, if it's a dissection flap or if it's a closure device or an ECMO cannula, I do not get imaging. I bring them right to the OR. We know what the problem is. But if we don't know what the problem is, I typically do get imaging. And my go-to, if their creatinine is okay, is a CTA, abdomen and pelvis with runoff, especially if they don't have a femoral pulse. And we found really interesting things that I would not have known. And so thrombosed limbs of EVARs, kinked iliac stents, obstructing flaps, even in aortic dissection that the patient didn't complain of any chest pain or abdominal pain, that was complaining of leg pain. And this was just a couple months ago. And so I do get imaging unless I know the cause. And so CTA, duplex, and the angiogram are your three. And CTA, in my opinion, is preferred. This is a really great test to look at the anatomy. Duplex, I think, tells you best the physiology. Angiogram will tell you both. It'll tell you both the anatomy and the physiology. It'll tell you, it's as you know, it's a video, and so you can see the flow. You can see if there's quicker flow going down the profunda versus the SFA, if there's a distal occlusion. And so if the patient has an elevated creatinine or the duplex was not helpful, I will bring him right to the OR and start with non-table angiogram. So if it's been 6 hours from presentation or revascularization, is there anything else that needs to be done before leaving the OR? And so I would say fasciotomy is the number one thing. In fact, I'm very aggressive with fasciotomies to make sure that I don't miss anything. And we've had patients die with compartment syndrome, and so and delayed recognition and even incomplete fasciotomies. And so these are all things that we see as a practice and across hospitals. Let's say you get a consult or a question for a patient that has a pulsatile mass in the groin. Maybe this was after a coronary angiogram. And so this is what you see. Here's your common femoral. Here's a large area which appears that there's flow within, and they call this the yin-yang sign. So there's flow going both to and away from the probe, so to and fro. And you can see that there's a long neck here. So this is a femoral artery pseudoaneurysm. A femoral artery pseudoaneurysm, like any pseudoaneurysm, is really a contained rupture. That's all it is. It's a contained rupture. And so in 2024, if you have a femoral pseudoaneurysm with an appropriate neck or length between the pseudoaneurysm and the common femoral artery, these can be injected with thrombin, and it typically only takes a tenth of a milliliter of thrombin to thromboses. And so you do this percutaneously. You could do it at the bedside or with radiology. And you have to make sure that you still have flow in the common femoral artery afterwards, that the thrombin doesn't propagate down, which is why you need a long neck. So that way the thrombin only acts on the pseudoaneurysm itself. This was another patient that we had. This was a patient with a large pulsatile abdominal or large pulsatile femoral mass, history of IB drug abuse, and you could see that there's to and fro flow, but this is really a blown out pseudoaneurysm. It's really difficult to appreciate. So we got a CTA, and you could see that this is essentially again a contained rupture. And so this is a patient that would need an open repair. Thrombin injection would not be possible. Peripheral aneurysms. There's usually a question on peripheral aneurysms on the test. So I think about this as I start at the popliteal and I go up. So popliteal aneurysms, the easy one to remember is 2 centimeters. So if someone has a 2 centimeter asymptomatic popliteal aneurysm, I will book them for either an endovascular or open approach, depending on if they can tolerate open surgery. And then going up, each level goes up by 0.5 centimeter. So femoral arteries, we fix at 2.5. External, internal iliac arteries, we fix at 3. And common iliac artery aneurysms, we fix at 3.5. So this is just an easy way to remember. Just start at the popliteal with 2, and then each level that you go up just increase by 0.5. All right, so moving on to aortic disease. If anyone has any questions, feel free to stop me. Otherwise, we can get through, so that way we can take questions at the end, and I can get through as much as possible if you like. So here's a CT scan. You can see here's our renal arteries. Here's our what appears to be a large aortic aneurysm. Here's the left renal artery coming off. Here's the SMA. Here's the left renal vein. And here's the sagittal view, and you can see this is a large suprarenal artery aneurysm. Here's the left renal. You can see that right renal here. And so aortic aneurysm disease. So what's the annual rupture risk? And so this is, I'm sure you've seen, very common. We get these consults not only in the hospital, but in clinic for aneurysms that were identified on incidentally on imaging. And so small aneurysms, we classify small aneurysms as less than 5.5. The annual rupture risk in men is low. It's less than 1% per year. And so as of now, we typically offer lifestyle modification. Smoking cessation is the only intervention that is proven to reduce the risk of propagation for abdominal aortic aneurysms. And surveillance. So that way, once they reach that 5.5 threshold, that they can be offered repair. So at 5.5 or 5.6, that's when that rupture starts jumping up exponentially. And so for men, we offer repair then. As you get into the sixes, the annual rupture risk increases to 10 to 20%. 7 centimeter aneurysm is up to 30%, and over an 8 centimeter aneurysm has up to a 50% annual risk of rupture. So open versus EVAR, this is one of the classic debates in vascular surgery. So the UK endovascular aneurysm trial, the EVAR-1 trial, the Dutch EVAR trial, and the OVER trial compared the two. And what they found is that the 30-day risk of mortality for elective EVAR is low. It's about 1 to 2%. And for open repair, it's about 4 to 5%. And that's why we typically wait to fix aortic aneurysms until they get to 5.5, is because the risk of mortality is above the threshold, the benefits when it's underneath 5.5. Once it crosses 5.5, then the benefits goes above the risk of repair. Some people use this data to say, well, maybe we should do EVARs at 5, but currently the guidelines are still at 5.5. So the national guidelines are still 5.5 for men and 5.0 for women. So what about long-term mortality? So long-term mortality is the same under 10 years. But if someone's expected to live over 10 years, open repair has a survival benefit. And so they cross at about 8 to 10 years. So if we have a young patient, a patient in their 60s or even in their 70s, if they are at appropriate risk for open surgery, I counsel them on open surgery and of course, give them the option. But there are clearly patients where open repair is much better for them. EVAR is not without its problems. Endo leak is probably the Achilles heel of EVARs. And so with open repair, we open the aneurysm up, we sew in a new graft. There's really no such thing as a leak since it's just sutured material on either side of the aneurysm. Versus an EVAR is almost a palliation of an aneurysm. So it's a stent that goes in the inside, blood goes through the stent, takes pressure off the aneurysm itself. So it could leak both at the top and at the bottom. And so those are called type 1 endoleaks. And so these will always need to be repaired because essentially you have an unrepaired aneurysm with a type 1 endoleak. Type 2 endoleaks is when you get return of blood from the lumbars, or let's say if you covered the internal iliac, any sort of return of blood into the aneurysm sac itself. The IMA. Type 3 is at the overlaps. And type 4 and type 5, we don't really see anymore. That's from graft porosity, or a term that was called endotension back in the early 2000s, where we really didn't know why aneurysms expanded. And we'd open them up and we'd get almost like a serous fluid within them. So this is an image of a ruptured aortic aneurysm. And so here's the blood in the retroperitoneum. So if you see this picture here, this is a ruptured aortic aneurysm. So a few scenarios that you're likely to get. Post-op day 3 for an open AAA for rupture, patient has a large delayed bowel movement. So next step in diagnosis. So the question is, what are you worried about? And I'd probably be most worried about ischemic colitis. And so sigmoidoscopy would be the next step. Colon ischemia occurs up to 7% in open AAA repair, and it's a higher risk if it's a ruptured aneurysm. It does happen in EVARs as well, but it's lower. It's about 1 to 2%. If you have a 75-year-old male who presents remotely after an open AAA repair with an upper GI bleed, what's your suspected diagnosis? And so for these patients, we're concerned about an aortic enteric fistula. This is an incredibly dangerous diagnosis. If stable, I would send them for a CTA. and that way you can identify the anatomy. You could see if there's air within the aneurysm sac. That's pathognomonic for an aortoenteric fistula, especially if they haven't had any recent manipulation. They haven't had any catheterizations for endoleaks or anything like that. If you may see a loss of fat between the duodenum and the aneurysm itself. You may see a blush into the from the sac into the small bowel. If they're stable, typically send them for urgent upper endoscopy to exclude other sources of bleed. This may identify a fistula, such as in this case, where you can see the graft itself that's eroded through into the duodenum. So here's a CT scan. You could see that there's possibly a bit of a blush here and all that air within that aneurysm, which is, again, typically pathognomonic. So in an unstable patient, the approach to this is classically a laparotomy, supraceliac aortic control, an excision of the synthetic material. And then what are you going to do after you excise that graft? And so you've got a few options. You can oversew the aortic sump. You would take a piece of omentum, bring it typically retrocolic, and tack that to the stump. The problem is that there's a risk of blowout. You can imagine that here you're getting 120 millimeters of mercury pressure at the end of a aortic stump that is diseased, that may have residual infection, and so this is typically not an ideal scenario. Sometimes you have to do it. Extra anatomic bypass, AX bifem or bilateral AX femoral bypasses, or in situ reconstruction. This would probably be the preferred method for your ABSITE. And so typically you may either use homograft, you can use rifampin soaked Dacron. Some of the other considerations is the virulence of the infection. And so Pseudomonas is typically the most virulent infection. Staph aureus we see in the early to mid post-op period, and Streptococcus is often the late infections. And these patients may present with weight loss, malaise, night sweats, and so on. I think I've got about 10 more minutes or so, and then we can take questions. We'll just keep going if that's all right. Aortic dissections. Here's an image of an aortic dissection. You can see the tear that's originated just distal to the left subclavian artery. And that dissection extended down all the way to the visceral aorta, and you could see the dissection affecting the SMA. So what's the first step in patients with type B aortic dissections? Well, the first is aggressive blood pressure control. And then we need to decide if they need to go to the OR. So which of these patients need to go to the OR in the acute setting? So malperfusion or rupture. So I've seen rupture twice for acute aortic dissections, and both of them did have connective tissue disease. Malperfusion is much more common than rupture. And so for patients that come in with aortic dissections, a pulse exam is incredibly important. Do they have malperfusion to a limb? Are they making urine? Do they have ischemia to the kidneys? Do they have an elevated lactate, ischemia to the small bowel? Is their transaminases elevated? Or do they have a hepatic ischemia? And so on. And I've even seen a patient with an obstructing flap occluding the intercostal arteries that wasn't able to lift their leg. And so even spinal cord ischemia is, while it's typically a consequence of repair, that also can be a malperfusion as well. So here's a TVAR, which is probably most commonly done for the acute setting. Typically in the acute setting, the dissected aorta is like tissue paper. And so it's very, very difficult to sew with. And so here's a stent that's placed just distal to the left subclavian. Many times we do have to cover the left subclavian artery to get that coverage. Here's an open repair. So this is a patient that had an aneurysmal type B aortic dissection that was being followed for several years. And you could see here's the septum between the two, and it's fairly thickened. It's almost hard to tell which is a true lumen and which is not. So we oversewed some of those lumbars during the repair. And here's the thoracic aorta, and so we did do an intercostal patch for that as well. Moving to mesenteric and renal disease, we typically talk about the four mechanisms of intestinal ischemia. So just like acute limb ischemia, there's embolic and thrombotic, but there's also additionally venous and non-occlusive or NOMI, non-occlusive mesenteric ischemia. So this is a classic picture for embolic mesenteric ischemia. And so you could see that while there is some disease of the aorta and a little bit of the SMA origin, it's fairly open at the origin. And you can even see the first adrenal branch, and then you could see that hypodensity here on the CT scan. And so typically embolic disease will spare the early adrenal branches. And you could see here that those early adrenal branches are still perfused. This may be an intraoperative consideration where the majority of the small bowel is affected and the ascending and most of the transverse colon is affected as well. This is opposed to orificial disease, which we see most commonly with mesenteric occlusive disease or thrombotic disease. So the goal is an acute mesenteric ischemia. So I start with a laparotomy. That is my my algorithm. I start with a laparotomy and evaluate if they need resection of necrotic or perforated bowel. And so if it's frankly necrotic or perforated, that gets resected. Then revascularization. And so revascularization, we can do open or endo. They already have the laparotomy anyway. So typically what I do is I get the SMA out and I'll access it with a micropuncture and a sheath and take a picture. And if we can just put a stent right across just from that SMA, it's usually very quick. And so we call that a retrograde open mesenteric stenting or a ROMS. If that's not possible, then you already have the laparotomy, you already have your SMA exposed. And so the quickest is, in my opinion, just to do a bypass. And coming off the the right common iliac artery is usually the approach with the least morbidity. You don't have to clamp the aorta. And then we typically reevaluate the borderline bowel, put an Apthera on, take them back the next day. I used to start with arm access or groin abscess and go up and shoot a mesenteric angiogram and try to get in. And with sometimes those orificial lesions, they can be very challenging. And so I've lost half an hour before saying, we got to go to a laparotomy. And so after that, my algorithm is start with a laparotomy, get source control, revascularization, reevaluate the borderline bowel. And I believe that this would be the algorithm for your ABSITE and for your boards. It's a 75% mortality rate, similar to a ruptured AAA. Mesenteric aneurysms, for some reason, are well represented on your test. Most commonly, the splenic artery, and in patients who are females in their pregnancy years or their able to be pregnant years. So typically, we fix splenic artery aneurysms when they're over 3 centimeters, all pseudoaneurysms, and in all sizes in women of childbearing age. The rest are typically if they have an aneurysm or not. Hepatic artery typically is a 2 centimeter threshold. Renal artery is a 3 centimeter threshold, usually because the renal arteries aneurysms typically don't rupture. Usually they more have occlusive disease. But the splenic artery aneurysm is the one I think is the most well represented. Going on to carotid disease. So here's the internal carotid artery. You can see the high-grade stenosis. This is a fairly high lesion. You could see the C2 level of C2 here. So to get up to do an endarterectomy is fairly challenging. So symptomatic carotid artery stenosis. So the NASCET trial is still the most commonly cited trial for symptomatic patients with greater than 70% stenosis. And so patients who are treated medically have a 26% risk of stroke in 2 years. But if they're treated surgically, that's reduced down to 9%. This was before statins. The best medical therapy was aspirin 100 milligrams. That's what the trial was. And so now we typically consult patients. Well, we can treat this. We can treat your symptomatic carotid stenosis medically, which probably has a little lower rate with statin therapy if they're symptomatic, or we can do combined medical and surgical therapy. And so that has an even lower risk of stroke in 2 years. And so if a patient is an operative candidate, I believe that that's the best option for them is combined medical and surgical therapy. Asymptomatic carotid stenosis is just like open versus EVARs. It's hotly debated depending what country that you're in. The ACAS trial, the reason that it says 60% stenosis is that's just what the trial was designed for. And so it's surgery cut the risk of stroke in 5 years in half. But many people will not operate on 60% stenosis. Most will do at least 70 or even 80% stenosis for asymptomatic high-grade stenosis. Carotid artery stenting. I just had a few comments on carotid artery stenting. So the CREST trial, it was done to look at the composite or the combined stroke, MI, or death, and it was actually the same between endarterectomy and stenting. But when you delved into it, you found that patients had a much higher risk of stroke with stenting and a higher risk of MI with endarterectomy. The other consideration is, well, what's the quality of life after a stroke versus the quality of life after an MI? And many patients after strokes may have debilitating strokes versus an MI may not be debilitating, may be caught with an elevated troponin or an abnormal EKG. So carotid stenting is probably significantly less preferred, especially transfemoral. TCAR has essentially replaced transfemoral stenting in I'd say 99% of scenarios, other than if patients had previous radiation or a stoma or any reason that you can't make an incision on the neck. So TCAR is essentially reduces that risk of stroke by connecting your sheath in the carotid artery to a circuit that reverses the blood flow in the internal carotid artery to prevent the showering up to the brain. I don't think we need to delve too much into that. Just a few anatomy, just wanted to go over this. Here's your carotid bifurcation. The internal typically goes straight back and the external goes towards the face. You'll see the vagus nerve run right with the carotid and the internal carotid, the hypoglossal, which comes down and goes towards the tongue. Typically, we ligate the common facial vein to expose that femoral bifurcation. Let's say that we can't get to the internal carotid artery. You have a high lesion. There's a few maneuvers that you can do. Probably one of the easiest is to divide the digastric muscle, which it's not shown here, it's retracted. Once you divide the digastric muscle, that exposes a bit more. Then you're still going to have this hypoglossal. And so here's a branch off the hypoglossal. This is the ansa. And so many times I may have to ligate this, and you do a medial rotation of the hypoglossal nerve. And so you may have some scenarios or some answer choices that say do a lateral rotation, do a medial rotation. It's a medial rotation of the hypoglossal nerve, so you can really get up there. The other options would be to sublux the mandible. If you know it's going to be a high bifurcation, I typically just do a nasotracheal intubation to start, and that gives you a few extra millimeters, and sometimes that's all you need. And we'll just do one more slide before we do questions. So let's say you have a patient that's during a carotid endarterectomy suddenly becomes bradycardic and hypotensive. So what's your next step? So this is likely a vagal reaction. And so typically give them glycopyrrolates. And I also inject 1% lidocaine into the carotid sinus. And so this blunts that vagal response. I think we've done this maybe 3 times over the past year or so. So my setup for carotid endarterectomies, I always have a 1% lidocaine on the Mayo stand for this exact purpose. And this is a question that is usually on the ABSITE. Well, I think I can keep going or we can do questions. Tan, are you there?
Yeah,
or?
I think we still have time, but there's one question. Is there a clinication for which we'll choose in situ reconstruction? over extra anatomical bypass in patients with aortic graft infection?
Oh, that's a great question. If you are suspecting that it's an incredibly virulent infection, I would say that many people will try to get out of there and try to oversew that aortic stump in a couple layers and then bring the momentum down. Um, if it's a patient that is stable, that maybe came in with abdominal pain and just has an infection and not a true fistula, many times we'll do an extra anatomic bypass first, and then do the resection and then decide at that point whether we oversew or do the in situ reconstruction. It's nice to have that extra anatomic bypass done first because then you still have perfusion to lower extremities and you don't have to worry about that. And so it likely decreases their mortality. But this is a very high mortality case. And I would say that if you can do an in situ, that would be the first preferable option.
Thank you. We have another 8 minutes. If you want
Okay,
to continue full
sure.
slides, that'd be good.
Absolutely. All right. Very good. And all right. So dialysis access. So this is also fairly represented on the ABSITE. So you need a 2 millimeter artery in order to accommodate for dialysis access, and the vein has to be about 3 millimeters or above. So why does this matter? So the vein, in order to receive enough blood flow, in order for the vein to dilate, has to have an increased amount of flow within the vein itself. And the only way that that happens is if the artery itself dilates. So if you've ever done redo dialysis access, you may notice that the brachial artery may be huge. I mean, it looks like a femoral sometimes. And so that's a compensatory response. So if you have a calcified radial artery, I would not even try to do a radial artery fistula for that. So I think it really depends on the response to the artery as well as the vein to have a usable hemodialysis access. So typically, we do the non-dominant hand first, and we tell patients that one access is not going to last them for their entire lives. And so we typically do non-dominant hand. So I typically do radial if I can, so a radiocephalic. So the next option may be a radial basilic. So if there's a nice basilic vein in the forearm, you can actually transpose that basilic vein and bring it over. After that, I typically do, you have the option to do a below elbow brachiocephalic fistula. Before going above the elbow, I may consider if the brachial vein looks good, I may do a forearm loop graft. So there, before you get to the upper arm, you have 1, 2, 3, 4 access options before moving to the upper arm. The downside of doing those access options in the forearm is that the rates of those maturing are much lower than the upper arm. So if you have a patient that has maybe they're just about to start dialysis or they're on dialysis or they're at high risk of catheter infection or their catheter is not working, then I go right to above arm, knowing that I want to get them a usable dialysis access early. But for your tests, typically it's wrist first and then move up the arm. And then once you have the upper arm, you can do brachiocephalic, brachiobasilic, brachioaxillary, axillary, axillary. So you've got about 4 options in the upper arm there as well. And so we talk about the rule of sixes for maturation for the vein for hemodialysis. So the vein diameter needs to be at least 6 millimeters. And so that's why when you do let's say if you do a graft, typically choose at least a 6 millimeter PTFE graft. So the depth should be within 6 millimeters from the skin. The flow volume should be 600 milliliters per minute. There needs to be also another 6 is that it needs to be 6 centimeters of length because there's typically 2 cannulas that are used, and so there needs to be enough length for those 2 to be accessed. And those that fail to mature should undergo fistulogram. So we just spoke about this before. So you've got many options for long-term dialysis and which do you start with first. And so typically it's non-dominant arm, fistula first if the veins are adequate, and you go distal to proximal. And so you have the options for below the elbow versus above. But the caveat being, if someone has an inadequate radial artery because it's heavily calcified, especially a patient who has diabetes, many times female patients, those radiocephalics are really likely not going to work. So I showed the answer here already, but so following left brachiocephalic AV fistula creation, your patient reports intense hand pain, but they still have a palpable radial pulse. So this is a condition known as ischemic monomilic neuropathy. And so this is a poorly understood condition that we think happens due to subacute ischemia to the nerves and due to competitive flow, and can only be corrected with immediate fistula ligation. And so many times it's, while this is a very incredibly rare diagnosis, I think maybe I've seen it once or twice in the past 5 years or so, that if it may be hard to diagnose because you may think, oh, maybe it's just from the block, or their block's wearing off, or the way they were positioned or something like that. So it can be very challenging. If there's any question whatsoever, and even on your question choices, immediate fistula ligation is the answer because it's irreversible. Let's say you have a patient who's had a previous brachiocephalic AV fistula, who now has worsening hand pain with dialysis and a finger wound, and there's reversal of flow. So this is Steele syndrome, or dialysis access-related hand ischemia. And so there's a few different options for this. Drill is very well represented on the ABSITE for whatever reason. And so what a drill is so here is your brachiocephalic fistula. And so you can imagine that there's competitive flow and reversal of flow from that distal brachial artery into the fistula. So what you do is you ligate that brachial artery so that way there's no reversal of flow. And then you do a bypass that goes from the upper brachial artery down to the either distal brachial or to the radial ulnar artery. And so it has to be at least 10 centimeters to do. This is, I would say it's the most common operation used for Steele syndrome. The other option is to do a Rudy. What a Rudy essentially is it's revision using distal inflow. And so what that is you're just ligating that fistula and using a vein graft to essentially create it to a radiocephalic. So you're converting it from brachiocephalic to a radiocephalic fistula. That's all really it is. And so I would say they've had both comparisons. They're pretty similar outcomes, but drill is the classic one for your test. Just a few words on venous disease. Chronic venous insufficiency is classified by the SEEP criteria. So clinical, there's different stages in advancement where C1 may be telangiectasias and C6 may be an active venous ulcer. Those are the ones I'd say are probably best on the test. And so it took me a long time to memorize these, to be honest. I forgot them after each test, but I can't imagine that you'd have to be able to match this for your ABSITE. I think mostly it's just identifying the trends and recognizing what is chronic venous insufficiency. And so varicose veins are typically not the classic chronic venous insufficiency that will need operations for the ABSITE. But if you have patients with pigmentation, eczema, edema, lipodermatosclerosis, those are towards the trends. The absolute indication to operate is a wound. That's the only indication to operate. You could do your entire career and never operate on venous disease except for an active wound. So that's the only reason to operate for your test. This was surprisingly on my ABSITE. And so it may have been VSITE as a fellow, but so where do you put in the tumescence when doing a vein ablation? And so it's within the saphenous sheath. And so the saphenous vein is right here. Here's the saphenous sheath on either side. And you want to put the needle right in the saphenous sheath. It looks like an eye where it's classically described, so that eye gets big. And so that way, when you have your frequency ablation catheter, all that heat gets absorbed from that fluid right around. So they may have A, B, C, D, E, different levels on where to put it. And so the answer is within the saphenous sheath. And just briefly going over acute venous thromboses. There's two types of phlegmasia. There's the albedolens, which basically just literally a painful white leg or painful white edema. This is what we call the cerulean phlegmasia. And so this is basically a complete outflow obstruction. So this is a surgical emergency. This is like a strangulated hernia. And so these are patients that need immediate revascularization. And so the classic answer was to make a small incision at the upper groin. And you can't pass a Fogarty down because of the valves. So what you would do is you would make a venotomy, you take a tourniquet, and you take an Esmark, and you just wrap starting at the foot all the way up and get all that clot out. And if you have a patient who's pregnant, that's how you do it that's how you do an open thrombectomy. Now again in 2024, 2025, we would treat this percutaneously, likely popliteal venous access, and then either do catheter-directed thrombolysis or suction thrombectomy. And usually there's a cause for this. And most commonly it's from iliac vein compression. And so most patients also will require an iliac vein stent. I used to watch the show before getting into others. Vena cava filters, there's usually lots of questions on vena cava filters. I don't know why it's so well represented. The only two indications are failure of anticoagulation or inability to anticoagulate due to bleeding. There's relative indications, such as a patient may have had recent spine surgery and they're going to be immobilized and they can't have prophylactic heparin or whatever the case is. So those are relative indications, but the only true indications are failure of anticoagulation or inability to anticoagulate due to bleeding. Sometimes you'll get questions on upper extremity DVTs and inability to anticoagulate. SVC filters are rarely, if ever, the answer. I don't think I would pick that on the exam. I don't think that's really ever going to be the answer. It's off-label. You'd have to either reverse, you'd have to take it off and reverse it and put it back on the delivery system, or you would use a femoral one and go through the jugular to deploy it. And so and there's a risk of migration. So there are some papers written about it, but I would not answer this for the ABSITE. And we are almost done. Maybe we are out of time, but thoracic outlet syndrome, just a few things. There's the venous triangle. And then there's the arterial neurogenic triangle. And so this is separated by the anterior scalene muscle. So the first rib is common to both. And so the muscles that attach are the subclavius muscle here. There's the anterior scalene muscle, and then there's the middle scalene muscle right here. So these are three muscles that attach to the first rib. And so when you're doing a first rib resection, those are the three that need to be removed. And so here's the triangle: is the first rib, the subclavius, the anterior scalene for the venous, and then the middle scalene. The posterior scalene goes on to the second rib. And so that's what you can see here. And I think we're out of time. Thank you so much. Is there any questions I can answer? Sorry, I went over.
No, thank you, Dr. Strasberg.